The most common clinical presentation of a patient of breast cancer is a breast lump. Now, what will the features of this lump, which if present, if we find, we can say, yes, this most likely is a cancer. So, this lump usually will be painless. It is firm to hard in consistency. Will have irregular surface, will have irregular borders, maybe mobile, maybe some mobility will be there, but can be fixed as well, can be fixed to the overlying skin, so they can be fixated to the skin, or it can be fixed to the underlying structures like the pectoralis fascia, the pectoral fascia, the pectoralis major muscle, and maybe even fixed to the chest wall. So, they may be fixity to the skin, they may be fixity to the underlying structures, that is pectoral fascia, pectoralis major muscle, or the underlying chest wall as well. Apart from this, what else the patients can present with? Apart from this, the patients can present with nipple discharge. They can be nipple discharge. Nipple discharge, any type of nipple discharge can occur in breast cancer, but definitely more commonly, which we have read earlier also in the benign conditions, is bloody. In breast carcinoma, the nipple discharge more commonly is a bloody nipple discharge. Then there can be nipple retraction. There can be nipple retraction. Nipple retraction is mainly because of contraction of the lactiferous duct. So, it's mainly because of the contraction of the lactiferous ducts which can lead to nipple retraction. Apart from this, there can be puckering or dimpling of the overlying skin. There can be puckering or dimpling of the overlying skin. So, apart from fixity, there can be puckering or dimpling of the overlying skin. Basically both of them, puckering or dimpling, are mainly because of involvement of ligaments of Cooper. So, puckering and dimpling, both of them are because of the involvement of the ligaments of Cooper. So, there's contraction of the ligaments of Cooper which can lead to puckering or dimpling of the overlying skin. Puckering can be seen even when the patient is sitting with the hands by the side, but dimpling always will be better visualized only when the patient raises the hands above the head. So, that's an important clinical difference which we should be knowing. Now, apart from this, there can be nipple deviation as well. So, because of the lump, because of the tumor, there can be nipple deviation as well. Now, these features, nipple retraction, dimpling, puckering, fixity to the skin, or nipple deviation, these are the features which are not going to influence the staging of the breast cancer. They are not going to influence presence of nipple retraction, nipple deviation, puckering, dimpling. They are not going to influence the staging of breast cancer. But there are certain other skin changes which are very, very important and which can influence the staging of breast cancer as well. So, what are those other skin changes which are very important and can influence the staging? First of them can be ulceration of the overlying skin. So, here we can see an image of an ulcerating mass, fungating ulcerating mass, due to a breast cancer. So, ulceration of the skin is because of infiltration of the skin or involvement of skin by the tumor cells. So, when there is involvement of the skin by tumor cells, that can lead to ulceration of the overlying skin. Then another very, very important skin change can be peau d'orange. Very, very important skin change. Peau d'orange, as all of you know, is mainly because of cutaneous lymphatic edema. When the dermal lymphatics, they get blocked by the tumor cell. It's because of cutaneous lymphatic edema, when the dermal lymphatics, they are invaded or they are blocked by the tumor cells. That's how it is called as peau d'orange. Gives appearance like a peel of an orange. And a third very, very important skin change which can influence the staging is the satellite nodules, or the satellite nodules of the breast. Or satellite nodules basically are nodules of the skin away from the primary tumor. So, satellite nodules away from the primary tumor, there can be nodules in the skin. So, this is just an image, there's a nipple retraction here and there is a presence of satellite nodules in this patient. There's a mass, there's a malignant mass with the presence of satellite nodules in the skin. So, that are the different clinical features, with which a patient of breast carcinoma can present. Apart from this, let's see how does a breast cancer spread. Breast cancer very, very commonly spreads by lymphatics. Very, very commonly it spreads by lymphatics. And by lymphatics, as we all know, it can go to the axillary lymph nodes, it can go to the internal mammary lymph nodes, and it can even involve the supraclavicular lymph nodes. So, these are the different lymph nodes which can involve the axillary lymph nodes, the internal mammary lymph nodes, and the supraclavicular lymph nodes, out of which definitely the maximum amount of involvement or the maximum chance of involvement is of the axillary lymph nodes, or the lymph nodes which are involved most commonly are the axillary lymph nodes. In fact, what happens is, a lot of patients, when they come to us, especially in our country, a lot of patients, they come to us in advanced stage. There's not a very well-defined screening protocol for breast cancer. So a lot of patients will come in advanced stage, and along with the lump in the breast, they're going to have axillary lymphadenopathy. So there will be axillary lymphadenopathy along with the lump in the breast. There is evidence of macro or microscopic axillary lymph node metastasis in around 60% patients of breast cancer. So in 60% patients of breast cancer, there will be presence of micro or macroscopic axillary lymph node metastasis will be there. And presence or absence of lymph node metastasis or presence or absence of axillary lymph node metastasis is a very, very important prognostic factor for breast cancer. So I can say axillary lymph node status. Axillary lymph node status is a very, very important prognostic factor for a breast cancer. In fact, it has been seen that patients who have a node negative disease, they have less than 30% risk of recurrence, while the patients who have a node positive disease, they have more than 75% risk of recurrence. So node negative, less than 30% risk of recurrence, and node positive, they have more than 75% risk of recurrence. So most commonly lymph nodes which are involved are axillary lymph nodes. Apart from this, there can be involvement of internal mammary lymph nodes as well, and internal mammary lymph nodes are usually more commonly involved when the tumors are in the inner quadrant of the breast, or maybe they are central tumors in the breast. So they are more commonly involved with tumors in the inner quadrant or the central tumors of the breast. So this is as far as I can say the regional metastasis in a patient of breast cancer, which mainly involves the lymph nodes, most commonly the axillary lymph nodes. Apart from this, the breast cancer can also spread by blood, by hematogenous route, and when it spreads by blood or hematogenous route, it most commonly goes to the bone. So the distant metastasis from breast cancer most commonly goes to the bones. In bones, breast cancer can produce both osteolytic and osteoblastic secondaries, but more commonly it produces osteolytic secondaries in the breast. So bony metastasis is more commonly osteolytic. Which bones does it affect? Yes, it most commonly affects the vertebra, and among the vertebra, it affects the lumbar vertebra. So the most common bone affected in a patient of breast cancer is the lumbar vertebra. And it is because, yes, we all know that it's because of the Betson's plexus. The tumor cells basically travel to the vertebra via the Betson's plexus of valvulus veins. So it is via this plexus that the vertebra get involved, and lumbar vertebra are the most common vertebra or the most common bones involved in a patient of breast cancer. Apart from lumbar vertebra, so the most common lumbar vertebra, apart from lumbar vertebra, it can involve the femoral neck. It can involve the thoracic vertebra. So these are, I can say, one of the three most common bones which can be involved by breast cancer. It can involve femur, it can involve the humerus as well, the ribs as well, the skull as well. But these are three most common bones involved in a patient of breast cancer. Apart from bones, so distant metastasis from a breast cancer, they are most commonly going to the bones. Apart from bones, it can go to the lungs. Second most commonly it goes to the lungs. It can go to the liver. Third most commonly goes to the liver, and can even go and involve the brain. So it can go to multiple organs. Most common organ involved are bones. Next most common are lungs, and the next most common are liver. So that is as far as the distant spread or distant metastasis of a breast cancer is concerned.